two panels to adjust to your convenience. We're going to use both the Q&A and the chat functions today. So if you have a question for the panelists, please enter it in the Q&A and the chat functions. And then you can also add comments in the chat. We'll also be using the chat for many links to the resources that are referenced. So keep your eyes on the chat for those additional resources. Today's session is being recorded and it will be available on the 2021 Texas Hypertension Control Summit Series page along with the slides, as are all the previous programs. So all of that is at within your reach, and you're free to share that with all of your colleagues and teams. So today we have, again, another full agenda. On this agenda slide, we can see some amazing perspectives from across the state to share. And now we'll be focusing on the pandemic and how it's affected hypertension control. We are certainly aware that it has taken a toll on control rates across the country. And I don't think Texas is immune to that either. We'll hear from 3 community and clinical leaders who will discuss their work, followed by a lively panel discussion. So please, again, remember to use the Q&A function if you have comments or questions for the panelists, and we'll look forward to having some discussion again at the end. So really, to kick things off, we're going to dive in with our first speaker, Dr. Alethea Chisholm. Dr. Chisholm is a graduate of Hahnemann University School of Medicine. She completed her internal medicine residency at Baylor College of Medicine. She's board certified in internal medicine and is a hypertension certified specialist. She's a member of the American College of Physicians, the Mary Sue Moore Medical Society, the American Medical Association, the National Medical Association, the International Society of Hypertension in Blacks, the Student National Medical Association during her training, and a national speaker of the House of Delegates. She is a board member of Hope Through Grace Incorporated, a nonprofit organization that provides medical support through cancer education, cancer screenings for the uninsured and underinsured, and survivorship skills for cancer patients. So it is my pleasure to turn the stage over to Dr. Alethea Chisholm to share their experience with COVID and hypertension. Thank you, Dr. Chisholm.
Thanks so much for having me to be able to participate in this particular very important webinar. So basically, we're going to be looking at control through the pandemic. And we've got probably, I'm going to start with the bad news and then hopefully end with some good news. Next slide. So this is the most recent NHANES study regarding hypertension, and this was pre-COVID, as you can see. So from 1999, we had been doing really well with controlling. These are rates of, this is prevalence, and I don't have the slide for the control rates, but it follows a similar pattern. And we've been doing really well. And then now there is an upswing in prevalence as well as control, and this is in all populations. Next slide. So one of the things that happened with the COVID-19, with the pandemic, we actually, the paradigm changed with respect to how we do things. So the pre-pandemic patient experience, there was the expectation of both the patient and the physician that there would be interaction, in-person visit, vital signs confirmed, treatment plan form, and follow-up. During this pandemic, that has changed. That system and that expectation has changed. So there are many patients who had healthcare system avoidance. They didn't want to come to the office. They thought that they may get COVID, that they may be exposed to something. So many avoided the physician interaction. Now there were choices with telemedicine. Some people, but that for most part required broadband for most people and internet service. There was some exception for in the Medicare population who were able to use phones, but a very different experience for many patients. And then for the physician having to rely on self-measured vital signs or maybe not, and just the follow-up. And then also limited follow-up going forward. So what we know that this has done is that it has separated what basically the way medicine has been practiced for many and many years. And then with the added insult and trauma of the actual pandemic on the part of the healthcare providers as well as the patients, we've now wound up with a system that has almost been untenable. Next slide. So this is actually a schematic of many of the things that have affected people with respect to blood pressure. And, actually you could probably put in any chronic condition for that. Because in primary care, as you are, very well aware, that's, the bedrock for chronic care for chronic conditions. So I'll start at the socioeconomic factors, stay at home with homeschooling. And for many people who are underserved and lower socioeconomic status, school is actually a built-in babysitter. So the idea that, we would have schools closed and somebody would have to stay at home, that took many people out of the workforce, and many of whom bore that burden were women in particular. Then, there's continuing to the right, there's a lockdown, self-isolation. And the third one to the right is the economy changes. And I can't emphasize that enough, because with the economy changes, if we look at people who are on the front line, and people of color were disproportionately in careers considered frontline or things that were unable to be transitioned to a home-based economy, many things happened with that. There were some people who were no longer able to work. Their jobs may have closed, particularly in the service sector, the entertainment sector, the restaurant industry. All of those took major hits. Those people in some of that economy were also tended to be underinsured or uninsured in those positions. And as well, just from, even if they were able to maintain their actual position, many had a reduction in income. So we know that there are many things that were put forward to try to alleviate some of that with, some of the governmental programs and stimulus and so on and so forth. But even with the stimulus package, it didn't really address the issue of insurance and actually access to healthcare. So our already fractured delivery system became even more fractured and even more tenuous. And then on the part of the individuals, there was, people became more sedentary. There was an increase of, unhealthy foods, much of which is, it's much cheaper to eat unhealthy than it is to eat, in a very healthy manner. Decreased physical activity, people were stressed out, a lot of anxiety, decrease in sleep quality, sleep duration, just in all the environmental circumstances. And as a result, we can anticipate an increase in blood pressure. So this was, really worldwide. And if you look at the data, there's a study from Italy, there's one from Oman, another one from Iran, with basically the same thing. Hypertension control became more tenuous and much more poorly controlled. And if you look at, some of the socioeconomic factors which we know exist in many of our populations with persons of color, these were just really exacerbated, as I have stated. Next slide. So this is actually looking at, the table is very difficult to see, but basically what I'm trying to show, there are many things in terms of who was controlling which part of this dynamic. The patients controlled it, had a great deal of factors, sleeping time, anxiety, and so forth. And then, so those were being managed by the patient or being directed by the patient. But then with respect to the physician, there in the middle section, the time for diagnosis of hypertension, therapeutic inertia, which we know already exists, in the middle of trying to, in many instances, save lives, take care of very sick people, make transition within your own practice and population. It was all just untenable and just really very overwhelming. So once again, as a result, all of these factors contribute to blood pressure being less well controlled in all populations. Next slide. Again, so this is also looking at the implementation of some of these different changes in our providing medical coverage. So now we've gone to telemedicine for many of the patients, and so the target group, so the patients were also had certain expectations in terms of looking at what the technology actually can do, if the people are able to buy into it, and then also dealing with physicians, many of whom now have to become more savvy, more technologically skilled, maybe required changing the setup, perhaps the electronic medical record for those who have converted, trying to make sure that devices and firewalls, all of those things, all of the technical back end portions that needed to be considered in this as well. Next slide. So in general, this makes for a milieu where everybody just kind of can throw up their hands and say, okay, it's just too much. So this is my own personal experience with as representation of my own experience with trying to maintain hypertension, some things that we were able to do. And I am in a large practice here in Houston. We have multiple locations, and we already had a pretty robust electronic medical record as well as telehealth system. And although we had capability, many of us, including myself, had not ever used it prior to the pandemic. And for those who were using it, it was a very limited experience, very small portion of our actual visits. So in March of 2020, we went to 50% of our physicians were in person, and 50% were at home. And we alternated for about a month before we came back into the office and still tried to direct much of our care in this manner. So it's very challenging and sometimes very time consuming. Other unintended consequences that are as a result of what we're having to do, social distancing. So if you think about it, if everybody's expected to wear a mask, and even if you have somebody pull down their mask briefly just to be able to see their face, there are many patients that I've seen since the pandemic started. I really don't know what they look like, and they really don't know what I look like. And I had somebody to tell me that I don't look like the picture on the internet. So you have all of these different variables of just the patient-physician interaction, that feeling of trust, that ability to be able to make more of a connection. And so those are the things that can be very challenging. We were able to overcome it by increasing our telehealth experience. Next slide. But out of this, we have the ability to turn crisis into opportunity for all patients, including underrepresented patients. And this is a quote from Clyde Yancey, who is a chair of cardiology at Northwestern University. "Public health is complicated and social reengineering is complex, but change of this magnitude does not happen without a new resolve. The US has needed a trigger to fully address healthcare disparities, and COVID-19 may be that bellwether event." And so with that, I will stop this part of the presentation and be happy to entertain questions at the appropriate time. Thank you.
Thank you, Dr. Chisholm. We really appreciate your remarks. Thank you for sharing some of the national data and patterns that that people are experiencing across the globe, and putting your personal and clinical perspective on that. We really appreciate that. We're really, again, encouraging everyone, if you have questions for Dr. Chisholm or any of the other speakers that you'll hear in the remaining two presentations before we get to the panel, please include your questions in the Q&A function. And keep your eyes on the chat function for helpful links. And we also encourage anyone who hasn't introduced themselves yet to do so. It's great to see so many new and returning faces to this community. So with that, we'll move on to the next presentation. It's my pleasure to introduce Laura Trevino. Laura has over 30 years of higher education administrative experience in the areas of mission, financial aid, program development, fund development, and community development. As regional director for the Texas A&M University Colonias program of the Lower Rio Grande region, she's dedicated a significant portion of her professional career working with community health workers. She has provided organized instruction for over 1,000 promotoras, community health workers, in accordance with the Texas Department of State Health Services. She's been a member of various collaborations that have developed and also co-authored multiple training curricula, including the RBI Border Violence Task Force and the Texas A&M Health Science Center. And through the work with promotoras with all these curricula, the curricula has been further informed and refined in a relevant, relatable, and culturally appropriate manner. Laura, welcome, and I'll turn the stage over to you. Thank you for being with us.
Good afternoon. Thank you. Thank you for everybody for this opportunity to share a little bit about the work that community health workers, or better known promotoras, do not only in our region, but really across Texas. And before I kind of jump into it, I'll tell you a little bit about how we got to where we are. And so one of the things we always focus on is people, individuals. What are the needs are? How do we respond? And so next slide. The way that we came about, Texas A&M, was that we were born actually out of a dissertation from a PhD student, a PhD candidate at the time, which resides here in the Valley. And through her work and effort and her dissertation, the central theme was people wanting to have access to information to better the quality of life for their families. Access to education, to training, to health, social services, etc. And so somebody within our college, the College of Architecture, took this information up to the Texas legislature. And since 1991, we have been funded, primary funding has come from the legislature. And so one of the core things we have done, one of the pillars has been to establish community resource centers, but always with the belief that community self-development is key and central to anything we do. And so we always have to listen, and that's key, listen to the community. And from there, the CRCs, or community resource centers, were established. And the next couple of slides, we can go forward, actually shows some of those community resource centers that were utilized. These centers are buildings that bring in various services and different things. But one of the things that we discovered is that the pillar of a building, the CRCs, such as in this slide and the next, are simply that, buildings. What you need is that heartbeat. And that heartbeat are the community health workers. So that was the next pillar or phase that we as a university went into. Next slide, please. And so this is a thrust of what my conversation is going to be about with the next few minutes that we're together. And community health workers, and the images there are pre-pandemic, as you can see, but that has stayed central and key even throughout the pandemic, is that promotoras go out into the community and they meet people where they're at. They go to their homes or go to the places they gather. And community health workers basically are culture mediators. They use culturally and linguistically appropriate language in speaking about different things that may be foreign to a family. And the way that's done is the promotoras will always engage in trainings with various leaders, such as the American Red Cross, such as the American Heart Association, diabetes, etc. Because as they go out and meet family members where they're at, they're able to learn and gain information and connect them to the appropriate resources. Next slide, please. The key to this is always trust. And one of the things that we have seen, and any organization who utilize the workforce of community health workers and promotoras, is that they're trusted individuals in the community. And the way that you do this is that you have to identify a spark plug, a chispa, as we call it in the community, somebody who is willing to gain information and share it with others. and more importantly, somebody who's trusted, somebody who lives within the community that they're serving. And this is essential because they become what we have dubbed 24-hour resources for their community, because they're seen at the local convenience stores fueling up their vehicles. You're seen at the grocery stores, at school functions, at faith gatherings, etc. So they're always going to trust, for example, a promotora, a community health worker on my team, more so than they'll trust me because they see me sporadically. They see them on a daily basis. And there's also a great level of responsibility that comes with that. So as an organization and programming, we always ensure to maintain the team with the most updated information. And the work with hypertension hasn't been any different because we were able to avail ourselves of some trainings provided by Eva Olivas to not only our team, but other promotoras within our community. And so they learned about things to look for, resources, different avenues. And so that team that already goes out into the community was able to connect families who were feeling disconnected to begin with. And then with the pandemic, even more so, because as Dr. Shannon explained earlier, this isolation that was being felt. And so that's been key to the different things that our team has done. And as you see in the pictures, I think pictures really speak more so than anything I can say, is that the promotoras, they go out into the community, they speak with families, they work with small presentations, what we call charlas or pláticas, which could be under a carport in somebody's porch, and they invite their neighbors. And so it's us going to them instead of them coming to sterile locations or buildings, as welcoming as we try to make them each time. Next slide, please. And these are a couple of samples. One of them is from pre-pandemic, and the other one is current, is that you can see the different avenues that our teams will take on. They'll go to large community events, now so a little different. They'll go to small meetings. And they'll also go, as you can see in the picture on the far right, this is outside someone's home. And that is a community leader who invited us and other organizations who have promotoras to come out and provide information on various health topics. Specifically on, always is going to be the request, hypertension, diabetes, and asthma. Those are going to be the three pillars. And we find that they all sometimes are distant cousins to each other, that there's a lot of common variables and common similarities. But key is always, and one thing I want to emphasize is that our teams will never sell themselves as a doctor, a nurse, social worker, a psychologist, scientist, etc. But what they do, what they are, they're bridges, or they call them las puentes. They're a bridge to the resource that has the information. But many times, I know that I grew up in a family of, ¿qué piensas, hijita? What do you think? We often rely on our family, friends, etc. And so community health workers, promotoras, have become that trusted vehicle in our communities. And so our partners have recognized that. And so we happily connect and collaborate with associations such as the American Heart Association to be able to bring credible information, accurate information, because we know there's plenty of misinformation out in the community. And so we avail ourselves of that information so we can then keep that in our toolbox, as we call it, and connect the families to the appropriate resources. But promotores have been doing this work in the state of Texas far longer than most of us have been around, because it wasn't until 1999 that it was formally recognized. But community health workers, promotoras, animadoras, whatever name you want to give, have been out in the community, which is a trusted individual in the community. And so during this time, our teams, even though we haven't been able to gather, with the relations that they built in their community that they serve, the community residents have reached out to them on various questions, including where do I go to get tested? Where do I go? Again, they're the trusted vehicle. And so even though we haven't been in large gatherings adhering to both local and state mandates, they continue to be that resource both formally and informally. Next slide. And I know that this is brief, has been a brief overview, but I'm sure there's going to be additional questions during the appropriate time. But community health workers are a trusted vehicle. Community health workers are an asset. Community health workers 23 years ago were only in nonprofit or university settings. Now we're seeing them in health settings and different things, because we are seeing that, such as the doctor said earlier, there is such a need for that connection. And many times our time is limited, that you need that additional team member to go out and connect and provide continued information and education. But I appreciate your time. I appreciate any questions that you will have for me at the appropriate time. And again, thank you so much for allowing me to share a little bit about what the community health worker is able to do, not only in this health issue, but in so many others. Thank you so much.
Laura, thank you. Really appreciate the perspective that you brought to the table and the important and evolving role that community health workers have played in healthcare delivery in general, in hypertension and the pandemic specifically. I really love the expression of a spark plug. We often talk about clinical champions in the healthcare setting, but I like the idea of a spark plug in the community. That was a new expression to me. So thank you. And again, as Laura mentioned, and please, if you have questions for any of the panelists, we encourage you to enter them in the Q&A function, and in the chat function, you'll see other comments, other links and resources that may come up during the presentation. So we'll move on to our third presenter before getting into our panel discussion. It's my pleasure now to introduce Joy Johnson. Joy is the director of Northeast Texas Public Health District, or Net Health Center for Healthy Living, where she supervises a group of community health workers. So we'll dig a little bit deeper into that topic. Together, they work to make free chronic disease prevention and self-management services accessible to higher risk individuals in Northeast Texas. Joy, it's a real pleasure to have you with us today, and I will turn the virtual stage over to you. Thank you.
Great, thank you, Allison, and thank you so much for joining the presentation today. I'm going to actually segue in from Laura's presentation and talk a little bit more about community health workers. So the Center for Healthy Living, you can go ahead and get to the next slide. It is a free resource for those in East Texas and even beyond to basically help people improve their health through behavior change, and also through many of the programs that we run through our Center for Healthy Living. Next slide, please. The center opened in 2013 at the site of an old fire station building donated by the city. And here's some of the programs that we offer at the Center for Healthy Living. So of course, high blood pressure, hypertension program is essential to many of the other programs that we run through the center. And we're also accredited for our diabetes program, and we participate in the National Diabetes Prevention Program. Next slide, please. Here are some of our community health workers. We have 5 now on staff, and we have 2 bilingual CHWs. We provide at our Center for Healthy Living free biometric screening. So anybody can come in now that we're reopened and get a free blood pressure check, free cholesterol check, free glucose check, and during business hours. So at that point, if we identify someone that has high blood pressure or their glucose may be high, we then have a more educational session with them, a more detailed visit, and we'll gather information. A lot of the clients who come in are uninsured and they do not have a doctor. So part of what we do is navigating them to our clinical partners who offer free or low cost care. Next slide, please. So how we use community health workers, well, since we're in the outreach department, we utilize health workers in a lot of outreach events. Prior to COVID, We would go to health fairs and bus stops, and like Laura's community health workers, we'd go where the people were. Part of what we did was provide free blood pressure screening, in addition to other screenings as well. And the same would be for those who visit our clinic. It would be the same way for outreach. We would identify those that had elevated levels of blood pressure, and we would then navigate them to resources in the community as well as primary care. And at the lower left, these are some of our graduates of our diabetes education program. And we also have been for several years, we offer the diabetes prevention program. We market it as healthy living because a lot of people are, they don't particularly like the word of diabetes, pre-diabetes. So we use it as weight loss marketing. And this all changed, of course, post-COVID, and we'll get into that when we are on the panel. Next slide, please. So I wanted to introduce you to one of the clients that we were fortunate to help during one of our self-measured blood pressure program cohorts. We actually partner with the Texas Department of State Health Services to offer blood pressure monitors to high-risk individuals with high blood pressure. And they are assigned to one of our community health workers where we follow them for 12 weeks. And we encourage them to check their blood pressure daily. We get those readings, but even more than that, it's a way for us to connect to individuals to find out what's causing their blood pressure to be high. Why do they, not take the medicine that they prescribed? And so there's so many factors that go into play with high blood pressure, as you know. So it really gave us the opportunity to kind of address those social determinants and then provide them with resources. And I think his stats are, if you hit the forward button, you may see, there you go. So a lot of our participants have really high blood pressure. Some of them don't know that they have such high blood pressure until, we arrive with our blood pressure monitor to check. And so it's an education opportunity for sure. Others weren't quite aware of how high their blood pressure had gotten, and they needed to go back to primary care. So some of the things that we've encountered is not having transportation to get to their healthcare appointments, not having support via their friends or family, maybe they're living alone, and then not having a clear understanding of what causes high blood pressure, what lifestyle choices may impact their blood pressure status. So for us, it's more than just another program. It's actually addressing these things with the clients who truly need them. And of course, the program that we use to navigate to healthcare providers, specifically for primary care, is utilized to increase medication adherence, and it's also to be able to control these blood pressures for people who may utilize the ED for their blood pressure management. And so we kind of segue into all of our programs, and we have that opportunity to enroll people in multiple programs that we have. And it's all because of our community health workers. So I will actually end early, and I will save questions if you go to the next slide. My contact information is on this slide. So if you have any questions, you can ask it during our panel discussion or send me an email. Thank you.
Joy, thank you so much. I really appreciate you sharing more depth on the important work the community health workers are doing, and look forward to a deeper discussion during the panel, which is upon us. So again, we encourage everyone to add any questions that you have for the panelists to the Q&A function. The chat, you're going to see more links and individual commentary, and encourage you to participate there as well. I do notice that there were a few questions. If anybody is looking for the slides or the recording from this event, or previous events. They all live on the registration page for the Texas Hypertension Summit. So you can go back there, register for the last remaining session, and find those additional recordings for your future reference. So now we're going to shift gears into the panel discussion, where our three presenters and moderator will have a lively discussion of this important topic. It's my pleasure at this point to introduce Leon Gerals as our panel moderator. Leon is the Director of Quality Improvement at Kelsey-Seybold Clinic. He has oversight of patient care, coding compliance, and the patient experience. He's a licensed registered nurse in the state of Texas and holds degrees in nursing, biological science, and both business and healthcare administration. Mr. Gerald's professional experience spans multiple levels of the healthcare delivery spectrum, including behavioral, public, acute, and ambulatory care. And in this combination of his education and experience, it really gives Mr. Gerald additional insight into bridging multiple care delivery modalities to enhance quality. And he has special interests, including the enhancement of cultural competency in the healthcare delivery, integration of information technology into the continuum of care, and balancing costs without sacrificing overall quality of care, all important endeavors. Under Mr. Gerald's leadership, the Kelsey-Seybold Clinic became the first system in the nation to be accredited as an accountable care organization by NCQA, a high honor. With that, I'll turn it over to Leon to moderate our panel. Thank you.
Good afternoon, everybody. I'm going to need to cut that bio down next time to make my head bigger than what it is. So I want to say, first off, thank everybody, the presenters. That was some very good information that people tend to not think about at times. We like to think that COVID was the big aha on health disparities, but health disparities have been around for a long time, and they're not going away anytime soon. Dr. Chisholm, you brought light to the disparities when it comes to hypertension. I think that is good for people to see and understand. And you two ladies have showed how you can take those disparities and use other tools to fight those disparities and get down into the nitty gritty and the trenches, down where the help is needed, and the use of our community health workers. We don't have community health workers too much in the field that I'm in, which is ambulatory care at Kelsey, but I have heard many times and spoken to many community health workers, and the work that they do in the community is like awesome. It makes me think that that's something that we just might need to kind of join our clinics with those kind of tools to get out there to our patients. It's getting harder and harder, and I think COVID showed us just how hard it is, that when you're used to patients coming to you and you having to get out there into the trenches and see those patients and go to their homes, and the COVID kind of just put a halt on that. So what are you going to do now? You have to be creative, use more video visits and everything. But everybody thinks that everybody wants to do a video visit, but research shows that a lot of people don't want to do video visits. They don't want that technology. They want to go see their doctors. So that in itself created a huge wall when it came to the outreach of patients. But given all that, I think that we're going to have a very interesting panel today. So we have a few questions for y'all. I want you to just to run and try to answer them all. Just, we're going to take our turn here. So I'll start with the first question. Can you describe how the pandemic has exacerbated health disparities in your population that you serve? Dr. Chisholm.
I'll start. A lot of that is related to access, because, my practice is skewed towards seniors. And so for the younger people, telemedicine was not that big a deal. But for the senior population, and which is not, to disparage all seniors, many of whom are connected in Facebook and everything else. But there is a significant portion of the population that are not connected. They don't have broadband, or they don't have cell phones, and, having to encourage grandchildren and, relatives to get them to be able to be connected. So I think access was a big part. Just in general, in terms of, because, people that don't have, people who are under-resourced are, again, under-resourced. And so they don't utilize, alternative resources in order to come in. So one of the things I did, which was kind of helpful, I, utilized the pharmacist. Anybody that I hadn't seen, even, for an extended period of time, for a year refill, I would encourage them to come in. But even for those in the pandemic, if it had been a couple of months, or maybe I had made a medication change or had done something different, and I hadn't gotten to them, I used the pharmacist to to let them know, okay, hey, at the time of the fill, bring them in. So that was one of the things, but in addition, I think, like I said, clinical inertia becomes a big deal. So for the population who's less treated, maybe not as aggressively titrated on medication, now dealing with overworked, overstressed, healthcare community, those are the things that are just kind of ingrained. And so people don't, make the assumption that everybody with the same presentation gets the same utilization of services as well as referral base. And we know through many studies that that is absolutely not true.
Thank you. Ms. Johnson, how did it affect your population?
Okay. Yeah, it significantly impacted our target population. They're typically more rural, and they have, as Dr. Chisholm said, less access to resources. So our community outreach pretty much shut down in March of 2020, as many people did. And that forced us to then be at the center, at like Laura said, at the building, which just goes against our fundamental principle of how we serve the community, where we go to them and we don't wait for them to come to us. And so now that we are post-pandemic, we're starting to gradually get back to it, but it's not at the level that it was pre-pandemic. So that's the biggest impact that we've seen.
Leon, you're muted.
Okay, you think I would have caught on by now. Mr. Trevino, tell us how it affected your population.
Thank you. Actually, the population that we primarily focus on is we work with communities in colonias, which is unincorporated communities. And so as it is, just by the definition of itself, they're remote and isolated from cities and resources. So that adds a different layer of challenge. And most of the families who live within colonias already have transportation issues. So this only compounded the situation even more. But this is where the unofficial networks really came into play, because the promotoras, the community health worker community themselves, have a lot of interactions amongst each other. And so they were able to stay connected and therefore connect to the residents. Because otherwise, as Joy mentioned, and as well as Dr. Chisholm, we were forced to kind of stay within four walls, which is very, very unsettling for those of us who are used to doing outbound outreach type of thing. And so, we did find that a lot of the families were not going to their appointments for fear. In addition to the transportation, fear was a big factor. And that's something that we started working with the local faith-based leaders on different things. So because people were still gathering in smaller numbers with their faith organizations. So we tried to connect with as many of them as we could within the communities, so that we would do the legwork and find out, because they want to know, is this doctor's office still open? What are the hours? And so it's almost like our teams were working behind the scenes to get information to the trusted voices and whatever that vehicle was for that particular community.
And thank you. So I work at the same organization that Dr. Chisholm works at. I know one of the things that we had that kind of made everything hard is that during the pandemic, we halted all of our outreach. So all those patients that we would reach out to for, your hypertension visit, your diabetes visit, or your diabetes testing, we didn't do anything for a good 6 months. So we had to play catch up, and we're still playing catch up today. So I think that in itself has set us back. We're still trying to get back where we were, and we're barely getting there now before the pandemic. So I have a next question. How do you ladies feel that COVID has changed healthcare as we know it? How has it affected your practice, and where do you think that change will go in the future? Ms. Johnson.
Yes, I am going to be optimistic and say that some of the good things that I've seen that came out of it is One, being flexible in our in how we deliver healthcare. We are now seeing that, because of limited resources, maybe we need to provide options like telehealth for those who are comfortable with it, and training to go along with that, because that's also a barrier. And then on the other side, I've seen more of an emphasis on health equity and how it differs from health equality. And we've actually received a grant for health equity, which is wonderful, because now we're able to, I think, really educate, especially clinicians, on how important it is for people who are more vulnerable to be able to access their care.
That's awesome. Ms. Trevino?
For us, I think it's helped us with something that we started with some years ago, is that, and it was in some of the slides, in small settings, in gathering folks with 5, no more than 10 people at a time. And in an era where the bigger the crowd, the more numbers, the more hits, that's where many times we give emphasis. The real value has been, because of the restrictions and for the protocols in place, we had to go back to small settings. We found that that's a very natural for us, and our partners started to recognize, oh, okay, there is a value to, let's have gatherings of 5, 6 folks versus, what do you mean the community event didn't gather 300 people at one time? We're able to make more of an impact because we're able to have more one-on-one conversations, more intimate relationship with the residents, and got to know them and what they're going through, and able to connect them to other things in addition to what the information we had at hand. And so I think that it just, I think, re-emphasized the importance of the small settings, small connections, because that's really where, that's how we started. And it's amazing how through all of this, that is what has allowed us to keep that connection with the communities and some of our partners.
That's great. Dr. Chisholm, what's your answer?
Well, and I agree with what our other panelists have already said, but I think there's going to be an increase, a permanent increase, pre-pandemic to post-pandemic, of telemedicine. And I think in doing so, I think there's room for improvement of what that whole process should be like on both ends, on the patient end as well as the physician end, because some things are just, people make the assumption that you can almost do surgery on a video. So that's going to take a lot of education. But I also think on a macro level, the things that we're talking about, equality, equity, because equity and equality are not the same, are going to make, and hopefully are starting to influence, major policy decisions. Because whatever we're doing at the local level, and those are really good things, and whatever an individual group, an individual practice, but ultimately, I think now that people are aware, and to actually see numbers of, disparate numbers with respect to death, there's no coming back from death, from something that, many people have. To be able to see that, I think that's, and I believe and I hope is going to have a forward reaching effect in terms of our policies at the local level as well as the national level, because clearly, our GDP as a nation in terms of healthcare is tremendous. But I think we maybe need to shift some of the resources and the actual dollars to some of these, low dollar, high value interventions.
That's awesome. One more question, or maybe, but how have y'all been able to ensure the continuum of your quality with all the competing priorities that the pandemic brought upon you, with this disruption of the flow and disruption of your normal processes? How did y'all ensure that quality was still where it was and where it needed to be? Dr. Trevino? I'm sorry, Ms. Trevino.
Actually, for us, we have our work is done with our partners. So we don't do that directly. And so we stay engaged with coalition, different things with some of our partners who are in the healthcare area, arena, and different things. And we're always kind of sharing back and forth information. I think one of the things that we've been talking about quite a bit recently is that I remember at one point there was a big thrust in increasing awareness amongst community residents on when to utilize an ER room and when not to. I think that it's thrusting us into the next phase is when is an in-person doctor visit appropriate and when is a virtual visit appropriate? I think that's the next area that many of the conversations are happening with some of our collaborations and partners here in the region.
Dr. Chisholm.
I think we're still going forward, needing to do, similar things. I think education is going to be a big challenge. Just making people aware, what expectations are to be going forward. There, and I think and that's going to be the reason that is a challenge, because that's just very time consuming. But in terms of, actual quality, is very challenging, because now I'm relying on people that I'm not sure I know. Diabetes is a little bit different because you can still be pretty objective in terms of blood sugar and diet and so forth. That's pretty objective. But in terms of hypertension, it is objective if it's being done correctly. And without having, any kind of assurance of what is actually being done, some of that trust was shifted from objective criteria, and now there are pros and cons to office blood pressures and so forth, and what you're doing, there's that whole conversation. But now, but at least you have some idea, some awareness of what's going on. And now that's being shifted really into a black box of, what patients are actually doing on their own, how are they managing things, if their income has changed, did they increase their salt content because, processed food is cheaper than, trying to get fresh food and so forth. So, you do the best you can, you make certain assumptions, try to have conversations with the patients and try to get a feel for what they're actually doing. But it's challenging, having them, write down things. And now they are finding that they are more responsible and have to have more of a stake in their own care. And then, have that, and they're part of the process is very important, has always been important, but now it's really, it's a greater percentage of what we're actually doing if we're not being able to rely on either in-person or some other kind of communication.
Thank you. Ms. Johnson.
Yeah, I will have to say for us, like you mentioned, Leon, it was very, very challenging. We had to shut down a lot of what we were doing. In fact, most of our programs, as the public health district, the center was staffed with a call center for COVID-19 for the community. And you can imagine how great that went. But, I think that it changed our perception of how we track success and what we count as something that is successful. Not losing a community health worker during the vaccination rollout, being the call center for that, was a huge win for us. But it also gave us the opportunity to look at the programs while they were on pause and say, let's start getting an evaluation, something that we've been wanting to do, and we outsourced that. And so it really gave us the opportunity to pause and look at how our projects are run, as we pretty much are starting over post-pandemic, and just seeing what exactly truly matters, what things could be changed. It took us out of our comfort zone. We're so used to just doing our daily work, and we don't really stop and think about the impact. And another thing that we wanted to emphasize is how do we get this out to the public? How do we let people know what successes are, what we have? We always share it with our partners, but we don't really think about sharing it with the community, with the people that we're trying to reach. So that was some shift in thinking for us.
So I lied. I have one more question for you ladies. If you could impart one piece of good knowledge in the future so they can handle their next pandemic in regards to the populations that you serve, what piece of information would that be? what would you tell them? What best practice would you provide them so they can be successful in handling the next pandemic? Ms. Johnson. Oh, I'm sorry, Dr. Chisholm, it's your turn.
No, is it, who needs this advice? Is it the patients, or is it the healthcare community, or what?
The next healthcare community dealing with populations like you serve.
Oh, I think the healthcare community has to get on top of the messaging. You know, and early on, people need to be aware, you know, that things change. It's a fluid situation. And I think, you know, some of the lack of trust early on was, you know, what people perceive to be misinformation or disinformation from healthcare leaders. And anytime something is new, you know, and that has to be reinforced, you know, over and over. This is something new. And I think if you get on top of that message in the beginning, that this is something that's going to be, you know, it's going to be trial and error, it's going to be painful, you know, decisions are going to be made and adjusted. And I think really getting on top of that messaging to the public in the beginning, and then just quickly for patients not to rely on disinformation, you know, follow the science.
Ms. Johnson.
My advice would be to build and maintain trust within your community. You know, like Dr. Chisholm said, the messaging is great, but if they have this mistrust of your system, or they don't really know who and what you are and what you stand for, the messaging will fall on deaf ears.
Thank you. That's very strong. Ms. Trevino.
And actually, along the same veins of the two previous panelists, you know, with the trust and the messaging, is also the healthcare community as a whole has to be open-minded about the various proven methodologies that can be helpful. Many times we get lost in, very importantly, titles and different things, but we have to go and find out who are the trusted individuals and get the accurate information into their hand, whether it be a community health worker, a pastor, a business owner, the gentleman that stays at the post office every morning and knows every single person in that community. Get him or her that information, and it'll get around the community. So I think that along the veins of what was said, we have to be different methods at work. Where is the trust in the community?
Thank you so much. Well, that comes to the end of our panel discussion. I want to thank you all for your awesome presentations, and that all this awesome, wonderful information that you've imparted today. And I want to thank everybody for allowing me to moderate. And I'm going to pass this on to Allison and bid y'all a good afternoon.
Thank you all so much. We really appreciate you sharing your insights into the wild year that we've all experienced. Appreciate recognizing the challenges of it, and yet the silver linings of it. And I certainly share in the spirit that I'm hoping this fast forwards our attention to hypertension control and thinking about new ways to deliver care. So with that, we're just going to shift gears for a moment. On the next slide, I want to just remark, I don't want to get ahead of ourselves because our next session of the Texas Hypertension Summit, the last in the series, will focus on, we'll highlight award winners in this year's Target BP recognition. But I also want to pause quickly to share a few details about the level of engagement that we saw in 2020, make the most of the remaining months that we have in the calendar year of 2021 so that you can achieve recognition next year, and highlight a few of the resources that are at your fingertips to do so as we prepare for the next wave of data submission in the new calendar year. So with that, if you'll go to the next slide, I wanted just to share with all of you, Texas has been so well represented in the Target BP recognition program. This is the growth in the program that we have seen over the last 5 years. And so you can see the patient population with hypertension that has been touched by participating organizations has grown from about 3.5 million to the high 8 million or more. We did see in this year's data submission slightly fewer patients represented, but obviously the conversation of today highlighted that many have seen declines in visit volume. The number of healthcare organizations participating has grown exponentially since the beginning. And then you can see how the different awards have been, sort of have panned out across that participating population. This past year, as you probably know, we launched 2 new award categories, the Silver and the Gold Plus, which emphasize evidence-based blood pressure measurement activities. And I'm going to talk about those in a second, but as you can see in this data, we saw fewer overall organizations achieving the Gold or Gold Plus level, which is not a surprise, again, given the decline in blood pressure control rates that we've seen nationally and that our speakers addressed today. But we were really delighted to see the high number of organizations, in the high 500s achieving silver status, recognizing their adoption of evidence-based blood pressure measurement activities. So we're really gratified to see the high level of engagement sort of against all odds in trying circumstances. And we're looking to build upon that in the next year. On the next slide, I just want to share a few more insights into those evidence-based blood pressure measurement activities. This is a little bit busy, so bear with me. The criteria that organizations had to attest to satisfying addressed aspects of calibration, validation, both of devices reflecting their accuracy, reflected aspects of teaching and testing our care teams on their measurement skills, and aspects of using a protocol or a systematic visual graphic in places where blood pressure is measured. And together, those 3 things, where the devices, the personnel, and the systems of care are aligned, really all 3 are critically important to achieve accurate blood pressure measurement. So what this slide represents, the top row of the top graph represents the distribution of attestation across all participating healthcare organizations. And so what this means is 48% reflected that they were calibrating their devices according to the requirements of the device, which, as you know, are different. Very frequent if you're using a handheld Android device, very infrequent if you're using an oscillometric device. And I'll save those details for your private reading. The next question about device validation, this doesn't mean that 100% of organizations were using validated devices. It means that they went to the new US blood pressure validated device listing to see if their blood pressure devices were on that new listing. So it's a new resource, and we were wanting organizations to become accustomed to checking that device, particularly as you're making new investments in your in-office or your home blood pressure measurement devices. And incidentally, that list continues to grow. There are several new devices that have been added in just the last few months. I got word that several more were just approved and will be added shortly, as well as more between now and the end of the year likely. So keep checking that validatebp.org. If we move into this sort of middle 2 bars here, 67, 68% of organizations reflected that they are both teaching and testing their staff every 6 to 12 months in blood pressure measurement. That is a skill that we learn early on in our training and often are never taught or tested again. And the guidelines are very clear that we should be testing and training and providing education around blood pressure measurement every 6 to 12 months for our care team. It's one of the most important skills we perform every day. There are a million ways to make mistakes, and that training is really essential to keep skills sharp, measurements accurate, and then treatment appropriate and accurate as well. A precursor to good treatment, a prerequisite, I should say. So, and then the last 2 categories, 83% of organizations reflected that they were using a blood pressure measurement protocol, providing systematic care. And just over half reflected that they used a visual graphic, an infographic in all places where blood pressure was measured. So some real opportunity here. And then you can see across the bottom of this slide how that attestation played out across different award categories. You also may recall, just one other point, that organizations need to attest to 4 out of 6 of these categories, these criteria, to qualify for the Silver or the Gold Plus award. On the next slide, I just want to dig into and highlight some resources that are available to organizations so you can make the most of the time between now and the end of the calendar year so that you're eligible for the highest award possible next calendar year. So on this slide, we'll focus on the first two criteria around calibration and validation. So calibrating your devices, it's important to calibrate your devices based on the type of device that they are. And encouraging you to check with your biomed team if you have one in your organization. Contact the device manufacturer as a second line of support. And then third, there are third-party biomed providers that can help with device calibration. And we anticipate providing more guidance on this in the future because it's a commonly asked question. So, but the first thing to do is to check whether you have Android or oscillometric devices, whether they're handheld or wall-mounted, and that will determine the frequency with which they should be calibrated to ensure accuracy. And next, I mentioned the validated device listing. It's important to check the VDL or a similarly regarded international device listing, but this is growing, as I mentioned, every day. With new functionality that allows you to search different device features and criteria. So those are some resources on the first two criteria. On the next page, I want to highlight some new resources for training your staff in blood pressure measurement. There continues to be a CME course where you can get a free enduring CME and CE credit on the Target BP website that staff can take independently or watch together as a group and brush up on their skills. We also have the Achieving Accuracy BP Measurement e-module also available. It's a 30-minute training that gives a half hour of CME CE credit. And then we continue to offer the free Technique Quick Check tool, great quality assurance tool that staff can perform peer review. You can have competency days. There are a lot of different ways in which you can use it. We also released to our field community impact field staff with AHA a Measure Accurately Watch Party Toolkit. And if you work, I would encourage you to contact your AHA community impact staff to get access to and collaborate with them on hosting an event like that in your organization. All of these resources will help you achieve these two important criteria in supporting evidence-based blood pressure activities. And then lastly, on the next slide, I'll just highlight resources available to you for these criteria, encouraging you to use a blood pressure measurement protocol. That can either be by using confirmatory measurements, meaning repeating a blood pressure measurement if a patient's blood pressure is initially elevated, or using ambulatory blood pressure monitoring, that's the 24-hour monitor. Not very many practices tend to have that, or using SMBP. So now that so many practices are using SMBP as part of their standard of care, there's sort of a new opportunity to incorporate that into your policy and procedure as a way to consistently measure and get representative blood pressures. And then lastly, this indicator, there were only about a little over 50% of organizations attested that they were doing this, hanging some type of visual reminder, be it the Target BP graphic, or there are others available next to every place where blood pressure is measured. So that could be hung on the wall, that could be framed, that could be put on a bulletin board in every exam room. You could make it your screensaver on your computers. You could laminate it and hang it from your pumps. I mean, or your blood pressure measurement devices. There are a lot of different ways in which that can be achieved that are compliant with your fire code or your other, this sort of the layout of your exam room. So encouraging you to do that as a visual reminder for your staff to measure accurately every time, but also for your patients as a way to partner with them and provide more reminders to them on how important accurate measurement is. All right, with that, I will go to the next slide, but I'll just make one last comment, and I believe Caitlin is adding this to the chat if she didn't already. We are going to have a Target BP webinar at the end of the month on the 27th, where we'll go into a little more depth on these items and also talk about some important streamlined data submission requirements next year that we'll dive into to prepare you and your team for what to expect. So some more details there. So thank you for sharing that link again to register for that event. So with that, we'll move into the closing of our program. Looks like we'll be able to give you a few minutes back, which I'm sure everybody will gladly have in their day. So we just want to close with a call to action on the next slide and a few more details. We really invite you first to take a few minutes to respond to the evaluation survey for this event. We read every response that we get and try to incorporate it into the next program. And we also look at the whole year's evaluations in total to plan the next year's series. So please take a moment to share your thoughts, share your stories. We're always looking for more fantastic panelists like the ones we had today and in previous sessions to bring these topics alive and into your home and your communities across Texas. I also want to highlight where you can find more information on the evidence-based blood pressure activities I was just mentioning on targetbp.org and on validatebp.org. I also want to highlight the resources available to you on the Heart Disease and Stroke Prevention website. And lastly, if you are not already involved in a regional collaborative in Texas, please contact our fearless leader, Cassie Hunt, to learn more about a collaborative in your area. Moving on to the next slide, I also want to highlight the next event, the last in our series. So please register and join us on November 9th for our celebration of Target BP awardees. And we'll also be sharing some late breaking science, particularly related to the AHA's new scientific statement about medication adherence and hypertension. Some really important information there that to inform ways in which we can intensify and support patients in successful management of their medications. And as was mentioned in the chat and the Q&A today, the recordings for all of the programs are available on that registration page for your future reference and to share with your colleagues. On the next slide, I just want to pause and this opportunity through the Texas Health and Human Services is still available through the Control Learning Collaborative. This is still open. There's a rolling application process, and I believe applications are still being accepted through December 10th. So encouraging you to learn more about the Texas Hypertension Control Learning Collaborative and related to SMBP and the awards available to support these grant activities. So thank you to the AHA and the Texas Department of State Health Services for this continued opportunity. And on a final note, on the next slide, I just want to thank everybody who has contributed to the planning of this event, both the team across the American Heart Association, the American Medical Association, the Texas Cardiovascular Disease and Stroke Partnership, as well as the Texas Department of State Health Services, those who have been in front of the screen, in front of the curtain, behind the curtain, playing really important roles in organizing this annual event. So thank you to everybody for your collaboration. And with that, I want to thank you again and look forward to seeing all of you in November to celebrate your recognition. Thank you for joining us.